Good morning, everyone. Welcome. We'll go ahead and get started. For those that are joining and entering, if you don't mind, please mute yourself if you haven't already done so. We are getting a bit of feedback. I want to welcome everyone this morning and thank you so much for joining us to the first discussion in our three-part series titled From Emergency to Everyday. We are very excited to have a wonderful panel today that represents really a wide range of provider roles within the newborn screening community, and we're looking forward to learning and hearing from their experiences and perspectives. My name is Mariana Rea. I'm the Associate Director of Programs at Expecting Health and the program manager for the Newborn Screening Family Education Program. Again, we're super excited to have everybody here and looking forward to a really great discussion. To kick things off and get things started, I'd like for all of you to take a moment to just pause and think about what you were doing this time 1 year ago. For some of you, you may have been figuring out how to set up a remote office and work from home. For some of you, you may be figuring out how to homeschool your children or become a homeschool teacher. And for many of you, you were probably doing both and many other things at the same time. We've really come a long way in the last year. And while most of the recent COVID conversations have been centered around looking forward and really moving beyond COVID for very good reasons, we feel that this presents a really unique and important opportunity to reflect and take a look back at what we've learned over the last year. There's a phrase that many of you, I'm sure, are familiar with, and that is hindsight is 2020. And so in each of the sessions that are a part of this three-part series, we're really going to focus in on hearing from groups that have been face-to-face interacting with families throughout this entire year to facilitate and support families through newborn screening. And we really want to look to understand what we can reflect on and learn from those experiences, so that in the future, as we encounter other emergencies, we can be better prepared to support families to the best of our ability. So again, thank you to our panelists and for all of you for joining today. I would certainly be remiss if I did not start by thanking our great partners at the Health Resource and Services Administration who support the Newborn Screening Family Education Program. This is a 5-year cooperative agreement, and we're currently in year 3. And the goal of this program is really to support families by providing education and training around newborn screening on all aspects of newborn screening. We've been awarded annually $400,000 to do this work, and we were fortunate that in this past year, we also received some additional funding to specifically work on newborn screening as it relates to experiences during COVID. So this work and this series has been great to work on, and we appreciate our partners at HRSA for supporting this work. A few quick logistics to get things started. We are happy to share that live captioning is available for those of you that may wish to have either live captioning or transcription. If you're not familiar, you may click on that, you may access that by clicking on the bottom of your screen, the more three dot button. And from there, you can select either turn on or turn off your subtitles or to view the full transcript. Additionally, if you have questions or if you have questions or comments throughout this session, please feel free to utilize the chat box that will be active. And we do have a number of individuals from the Expecting Health team manning questions and can help with any technical support that you might need. So before we jump in, we would like to learn a little bit more about who's joining us today. So we're going to ask you just to respond to a few quick questions to share a little bit more about who you are and why you're here. So we'll give you just a moment to respond to this, and then we'll be happy to share these answers with you. Give it just a bit longer. It looks like we still have some people responding. Fantastic. Thanks everyone for taking a moment to do that. And it's really great to see that we do have quite a range of individuals joining us today. So we have a few parents or expecting parents, and we have several representatives from the newborn screening programs. We have several advocacy representatives, healthcare providers, and researchers. So it's great to see such a diverse group of individuals interested in coming to join us. Lots of people who are here to listen and learn. So we definitely look forward to doing that ourselves. And then quite a range as well in terms of how much we all know and have experience with newborn screening. So thank you for sharing. So just by way of learning objectives, what we hope to walk away from after this initial session is really to have an understanding of the key groups and stakeholders that are involved in newborn screening, and particularly in supporting families through the newborn screening process. We want to learn how specifically healthcare providers have supported families through that process, given a global pandemic. And then I think the most important thing that we want to discuss and take away from that discussion is how can we apply those lessons learned? You know, we've all had a lot of experience over the last year. How can we really take what we've done and apply that to supporting families through future health emergencies, and potentially even in the scenario where there are multiple emergencies happening at the same time? So again, we are thrilled to have an amazing group of healthcare providers who have been supporting and working with families both long before and during COVID join us today. So rather than me reading a very long list of impressive accolades for each of these providers, I think it would be most helpful to have them introduce themselves. So I'm going to ask that Dr. Finlan, you start, and if each of you could just briefly share who you are, where you work, your role there, and how you're involved with newborn screening specifically, that would be amazing. So Dr. Finlan, would you like to start?
Yeah, absolutely. Thank you so much, everyone. Good morning. My name is Ursula Findlin. I'm a research audiologist at Nationwide Children's Hospital in Columbus, Ohio. I'm a clinician researcher, so I have 18 years of experience in audiology, which means I've been able to perform newborn hearing screening in birth hospitals and NICUs. I've completed diagnostic follow-up for referred newborn hearing screening in our clinics. But because I'm interested in research, that's a passion area of mine where I like to study how well we do newborn hearing screening and how we can make it more efficient. And that's my role here at Nationwide Children's Hospital. So thanks for the opportunity for this morning.
Great, thanks, Dr. Finlan. Dr. Gambello?
Good morning, everyone. Thanks, Mariana. So I am a medical geneticist and division director at Emory University School of Medicine. And I'm also the principal investigator of the newborn screening follow-up program for the state of Georgia. And so I'm really excited to talk to you about some of the ways in which we have modified what we do to take into account this little challenge of COVID-19.
Fantastic. Thanks, Dr. Gambello. And Dr. Suhendra?
Good morning, everyone. My name is Michelle Suhendra. I'm a pediatrician. I worked in corporate medicine and as an employed pediatrician for several years, and then just opened up my own private practice clinic in the Woodlands, which is a neighborhood just north of Houston, Texas. So we've been open for about 5 months now. And my role in newborn screening is really obtaining the screens and making sure that patients follow up. Here in Texas, we have 2 screenings. So kind of that process in Texas, though. Thanks for having me.
Thank you all so much. And, we just appreciate your willingness to share your experiences with us so that we can all learn how we can support families moving forward. So as many of you probably recall, when you registered, we wanted to find out and inquire a bit more about your personal experiences with COVID-19. And so we wanted to share that data with you because I do think it is quite interesting. So we asked specifically for, as you registered, for you all to share whether or not you thought COVID-19 has positively or negatively impacted newborn screening, making it either more or less difficult, or if you think perhaps it stayed the same, or if you weren't sure. And so not terribly surprising results here. I think almost half of those, and we had roughly 110 individuals that registered. So out of that, about almost half thought either COVID-19 has certainly made things more difficult and perhaps less efficient or less effective. But there's also a large number of you all that just really aren't sure. And so I think in the following questions and discussion that we have with the panel, we hope to shed some light on what has worked well with regard to newborn screening during COVID, and perhaps what have been some of the barriers. But most importantly, what are the creative ways that these providers have worked with their teams, their institutions, and their communities to overcome those barriers so that interruptions and access to newborn screening was not as severely impacted. And I think before we really move into the discussion, it's important to just set some context of why are we having this discussion now? And as I mentioned earlier at the beginning of the webinar, now is really the right time because we've been doing this for over a year now. And it's really a great opportunity to just hit the pause button and reflect back on what have we done, what has worked well, what can we continue doing, and what are things that we need to think about doing differently. I think an important point to this overall discussion is just truly understanding the complexity and the depth of involvement in the entire newborn screening system and the entire process of newborn screening. So even before, and I'll talk about this again in just a moment, even before COVID occurred, the newborn screening process and the different groups involved in newborn screening that work with families throughout that process is quite complex. When you add a pandemic to that complex system, it adds additional layers of complexity and levels of communication that need to be overcome or worked within. And so I think just having the discussion now, it reflects the right time of when to do that. And most importantly, as I've said many times already, we're just thinking about what can we do to continue supporting families without interruption of these services and to provide the right level of support and resources. So just to highlight, I know many of you on this call are already extremely familiar with the newborn screening process, the multiple parts within that process, and the different groups of individuals that work with families throughout that process. But for those that aren't as close to that on a day-to-day basis, what we wanted to highlight here is that there truly are just different components of the process of newborn screening and different interactions between healthcare providers and other individuals who are supporting families through that. So many families first hear about newborn screening during their pregnancy. An OB or perhaps even a pediatrician may introduce the idea of newborn screening while a woman is pregnant. After delivery is when newborn screening typically takes place. And so some individuals are introduced to the concept of newborn screening at that time. Some families who do experience an out-of-range result interact with a different set of providers when they have that result and have to do confirmatory testing. And then finally, once a diagnosis, if a diagnosis is made, there is management that is needed to support those families. So at each of these junctures in the newborn screening process, there are different touch points that a family has with different groups of individuals. And we've highlighted this here. In no way is this comprehensive of all individuals that do interact with families throughout this process, but simply to show that it is a lot and it is complex. And truly the only constant through that process is the family that is going through that experience. And so it's extremely important to learn from all of these groups of individuals that are interacting throughout the different points of this process to learn and reflect on what they've done successfully to support families. So for the discussion and for setting the context of how this will flow, both within this particular session and our future sessions in this series, we really want to take the approach and use the framework of asking these providers, what did you start doing when COVID-19 first started? What did you stop doing? And now that you've had a year of doing this, what would you like to continue doing in the future? And what can we build on as a framework for future emergencies? So we'll get started with what did you start doing to support families when COVID first hit? And Dr. Gambello, I'm going to open this up with you. I know one of the first things that you mentioned having to establish pretty early on was telemedicine. So we'd love for you to elaborate a little bit more on how you did this, and in particular, how you thought through which families you would bring in person to your clinic and which families you would see via telemedicine.
Sure, thanks, Mariana. The first thing that was done within Emory Healthcare as a whole was to spearhead telehealth in a way that was using the best practices that people knew at the time, and also to make sure that there are certain legal ramifications, right? So the patients had to be within the state of Georgia, which sometimes posed a problem. But so we had frequent Zoom meetings, of course, on how to deliver telehealth. And I think we learned a lot about telehealth over the year. And I think in the beginning, all of our visits were telehealth. What we found to be extraordinarily helpful was for the families who were geographically quite far away. I think, as many people know, there are few genetic centers per state. And Emory is really the only follow-up metabolic clinic in the state of Georgia. So, if you have a child born in Savannah or Valdosta, Georgia, I mean, these are 4 or 5 hours away. And so you're talking about a family taking an entire day to go to Atlanta. In the past, the traffic in Atlanta was a lot better. And so one of the good things about the pandemic is that the traffic in Atlanta isn't as great as it was before the pandemic. But I think that being able to see these families in the comfort of their own home was really a wonderful thing because it saved them a lot of time, a lot of money, a lot of effort, especially, you have a new mom and dad, their baby had this abnormal test, which typically frightens them beyond belief, and then having to drive 5 hours both ways is a big deal. So I think that was really a great outcome of the pandemic, was developing telehealth.
Absolutely. And on top of all of that, just having the fear of COVID itself and the risks that getting COVID presented if you were to visit somewhere in person. So I can certainly see how that was advantageous. Great. Thanks, Dr. Gambello. Dr. Findland, would you mind sharing a little bit with us about the setup for hearing screening in Ohio? And in particular, I know one of the things you mentioned was having to really advocate early on to continue newborn hearing screening, as an essential service. So would you mind sharing a little bit about that with us?
Yeah, absolutely. So every state has an early hearing detection and intervention program, or what we call an EDI program. And every state takes a little bit of a different approach to newborn hearing screening and follow-up. In the state of Ohio, we do 2 newborn hearing screenings in the birth hospital. And overall, the national goals are to have every baby screened for hearing loss by 1 month of age, diagnosed by 3 months of age, and then enrolled in early intervention by 6 months of age. The reason why we have those specific benchmarks is because all of the data tell us that if we do not identify babies who have congenital hearing loss before 3 months of age and get them into proper amplification and early intervention services by 6 months of age, it will have very significant long-term impact on speech and language skills and then overall academic achievement. So what we were able to do was pool some resources with other children's hospitals in Ohio, but also nationally, and provide that efficacy data to our hospital administration to assign newborn hearing screening follow-up as an essential service. And we were very successful in that endeavor. Our hospital administration is very responsive to efficacy data. But in the state of Ohio, we're one of 5 freestanding children's hospitals, and then we have 2 or 3 more outpatient specialty clinics for pediatrics, and then even more other diagnostic centers that do follow up to newborn hearing screening. And at one point in the pandemic, we were only one of 2 centers in the entire state that were still doing follow-up diagnostic testing after a failed newborn hearing screening. So everyone had a little bit of a different success rate with advocating, but we pinpointed diagnostic testing as essential even during a pandemic at our facility.
Fantastic. Thank you, Dr. Finlan. So I'm going to transition a little bit here to asking both Dr. Finlan and Dr. Suhendra to elaborate a little bit on the specific strategies and tools you used to complete the work that you just mentioned, Dr. Finlan. And so I'll have you go first, and then Dr. Suhendra, I know one of the things that you shared with me is obviously having to set up telemedicine. I would love for you to elaborate as well on you established a private practice in the middle of a pandemic. And so not only are you establishing telemedicine, but you're also establishing a private practice. So I'd love for both of you to elaborate a little bit on that. So Dr. Finlan, let's start with you. And if you wouldn't mind, I know you actually took an evidence-based approach and created some pretty specific tools to help support providers and others that are referring to you all. Would you mind elaborating a little bit on that experience?
Sure, absolutely. So we partnered with our state EDDI system that's housed under the Ohio Department of Health, and along with a number of audiologists across the state at children's hospitals, we came up with a guidance tool, and the link to it is right there. It's on the ODH website. We wanted to provide a prioritization or triaging tool for diagnostic centers. So when things did open back up and we were able to see babies again for diagnostic testing, for confirmatory testing for hearing loss, that we were able to see those babies in need in a more efficient manner. So we know from the data that babies who do not pass their newborn hearing screening in both ears are typically at more risk for hearing loss as opposed to babies who only pass in one ear and do not pass in the other. So we suggested to facilities that they triage babies who had a bilateral referral on newborn hearing screening first, as well as older babies. So babies who were born earlier in 2020 who were coming in for testing needed to be triaged first, because there's only a very short window of time where we can do a really effective diagnostic hearing test in natural sleep. So we test babies when they're sleeping naturally, and by the time they're 5 to 6 months of age, we actually have to switch over to sedation to test them for a bit of time. So we provided these evidence-based guidelines for our facilities to triage in order to basically get ahead of the surge of patients that were going to be coming in after the shutdown time period that we had here in Ohio, which happened between March and about June.
Fantastic. Thank you. Dr. Suhendra, can you share a little bit with us about what you had to quickly set up and establish within your private practice? And I know you leveraged a lot of the tools that are available through your state program. So can you elaborate a little bit on that for us?
Yeah, so starting a practice right in the middle of the pandemic was interesting. I knew that we would have to use telemedicine a lot and a lot of getting information to the patients electronically or digitally. You know, I've had a couple of patients who've had abnormal newborn screens, and my preference is to relay that information in person. During a pandemic, there's a lot of discomfort with coming in just for something like that. So we leveraged telemedicine for that. I think there's something to be said for when they can see on my face how serious I am about a disorder that's, could have potential lifelong consequences versus if I'm like over the phone, I can't really convey that importance. The other thing that was really helpful was through this website that I use to do all of my telemedicine. I'm able to also provide links for the newborn screening handouts that are good for parents, providing them more evidence-based medicine instead of them just Googling information about different disorders and finding out things that may or may not be correct. So telemedicine, electronics, this is all very key to practicing medicine these days.
Yep. Was there anything either of you wished that you had at that time that you weren't able to access or have in terms of tools for families?
Just going off of what Dr. Suhendra said, I wish I had a magic wand to erase all of the misinformation on the internet about different disorders and whether follow-up is needed or not. We sometimes get reticence from families and even providers, medical home providers, saying, well, most kids who don't pass the screening, you really have normal hearing, so they don't really need to go in for a confirmatory test. And that's one of the worst misinformation, at least in my field, because we tend to get those babies in when they're 2 and 3 years old, when they don't have normal speech and language development, and we've missed the boat on the critical period of language development. So that's what I would like access to in a magical world, but hopefully just at least being able to provide better, more accurate information in the future would be great.
Kind of going off what Dr. Finland said, social media can also be quite detrimental in terms of feeding misinformation out there. So that's been challenging because everyone's bored and on their phones and on social media all day long, and they join these groups that may or may not be providing the correct information.
Yeah. All great points. Thank you both. So we're going to transition now into a sort of different portion of the discussion. But before we do that, we have another poll for you all and would really appreciate your input here. I think one of the things you've already heard a little bit about and that we'll discuss more in just a moment is just the interruptions or the potential interruptions that families and others supporting newborn screening may have experienced during COVID. And we're intentionally asking this question in a very high level manner, understanding that we have a varied audience. We have, a variety of different individuals who are listening in and tuning in. And so your specific interruption may be very specific to your experience. And we really are wanting to understand or get insight if you feel you've experienced any interruption in the newborn screening process throughout COVID, whether that be from a provider perspective, in terms of diagnosis or time to diagnosis, if it's from the family perspective and that you didn't have access to information or had a challenge getting an appointment that you needed. And we're just trying to seek understanding from this group if the feeling is that you did or did not experience interruptions in the process of newborn screening. Give it just a minute longer. Fantastic. So so hopefully you all can see the results on your end, but about 70% of you all expressed that yes, you feel like you experienced some form of interruption at some point in the newborn screening process due to the COVID pandemic. And that's not surprising to me. That's consistent with things that we're hearing. So it's just interesting to have the data to support that, or some data to support that. I think in the next section, we will definitely highlight some of those initial barriers and some of the consequences of those initial barriers presenting delays or interruptions in the process of newborn screening for families. So thank you for that. So as we move into this next section of really thinking about and asking questions to this great panel of what did you have to stop doing when the COVID pandemic hit? And Dr. Gambella, we'll start with you again. I know you expressed or have expressed sort of a number of immediate barriers that presented, and having to work with your team to think through how can we overcome when the outpatient laboratory shuts down and we aren't able to bring patients back in for a blood draw, or when the state laboratory has employees themselves who are dealing with COVID and may not be accessible in the typical manner. So can you share a little bit more about those early experiences?
Sure. So the state laboratory and all state laboratories have emergency procedures so that if there is so for example, if everyone in the state lab had developed COVID, samples could be sent to another state, and that's already in, Texas has that. If there's a hurricane, what are they going to do, right? So thankfully that wasn't too big of a problem. I think one of the problems was getting laboratory follow-up done in a timely way, because typically we would see the babies in our clinic and then send them to the children's outpatient lab, and they're just very good at drawing lab from babies. Whereas we were doing this all by telemedicine, and we were sending requisitions to the families, and they would go to a local lab, and not uncommonly, they had difficulty getting blood from the baby, right? So the follow-up process was often longer than we would have preferred. The other issue is, while telemedicine is a wonderful media to use to deliver care, it has limitations, right? I cannot palpate the baby's abdomen. I cannot listen to the heart rate. I get some assessment of a baby's tone by looking at, and it also depends on how facile the family is with telemedicine. Oh, and the other thing is, if I had a magic wand, I would give everyone excellent internet access, because that is a problem. There are rural areas where you have an awful telemedicine experience. The other thing is I would teach people about adequate lighting. Because it's not uncommon, the family are backlit, and then everybody looks like a black silhouette. And so those are some of the challenges. I think that about summarizes it. One of our dietitians said the other difficulty was sometimes teaching parents how to mix formulas over telemedicine, as opposed to, physically being there, how much water, show me how much you're gonna, so those are just some of the challenges that we had to deal with.
Yeah, absolutely. I think you're probably not alone in some of those challenges. So Dr. Sahendra, you touched on this a bit earlier as well, but I'd love to hear a little bit more and have you share really what you had to think through in terms of how you perform newborn screening, particularly in your office, and how that may have changed in comparison to how it's typically done due to COVID.
Right, so in Texas, we are a state that requires 2 newborn screens. So we have the first one done usually at 24 to 36 hours in the hospital when the baby's still there. And then regardless of the results of that, we repeat one at the 2-week checkup. When the pandemic first started, I was in a place where we referred all of our patients out for that second newborn screen. We would send them to a lab to get it done. people were really hesitant to come into the office, just period. And so often, and they really didn't want to go to a lab where they would also see like grown adults who were sick and coughing, who are getting their labs drawn. So we pivoted and we said, well, we know that there are other states that only require one newborn screen. And so at that point in time, we decided if the first newborn screen was normal, we would just forego the second newborn screen, assuming that the baby looked fine and was thriving and gaining weight appropriately. Since then, though, in my private practice, I've made sure to get all the equipment necessary to do the second newborn screen. So we are again in compliance with the Texas regulations. But, it was something that we felt was necessary at that time to avoid exposure, not only to a second location, but possibly to sick, because, we know babies and pregnant moms and newly delivered moms are all immunocompromised. We just didn't feel like it was worth risking their health.
Yep. And I think that's, these questions are exactly the point of this, is to sort of reflect back and be able to ask yourself, if this happens again, or if something similar happens again, would we do it the same way? What would we change? And so I think there's a lot to be learned from what you had to do in those moments and what you're now, doing and going back to. So, Dr. Finland, I know you have been collecting data, as you shared as well, in terms of the quantitative impact of potential delays to newborn hearing screens. And so we'd love for you to walk through some of that data and share a little bit about what you know thus far.
Yeah, absolutely. So again, we partnered with the Ohio Department of Health to look at our follow-up. So what we were reported from the Department of Health is that we didn't have a significant change in the number of screenings happening, because those screenings were happening in the birth hospitals. But this graph depicts the number of missed infants for that diagnostic step, or that confirmatory step of congenital hearing loss. And it's graphed per birth month. And I've provided both the 2019 data and the 2020 data to compare what we see in a typical year versus an atypical year. And just to note, the data stops in September of 2020, only because these data were pulled in January. And kids who were born in the last quarter of 2020 were still kind of in the process of potentially getting their diagnostic testing. But if you click through, you can see between March and about June, we had that time period of outpatient care reduction. So even though our facility stayed open to do diagnostic testing for infants, not every facility did. And then we also had family reticence to come in. And we had a stay-at-home order that said, unless you are in an emergency situation, you need to stay home. So what you can see from this graph is that babies who were born in February, March, and April, in those time period, in those months, we had a larger number of infants who did not come in for diagnostic testing. And when we compare that to 2019, just looking at the average number per month, every month in 2019, we had about 157 babies who were not followed up for their newborn hearing screening for a diagnostic phase. But in 2020, that number jumps to 197. And this is only partial data, so hopefully this is improved, but we can't state that it hasn't or has improved specifically, mostly because there's still a significant amount of family reticence to come in. So currently, we have about an additional 480 babies who have not received diagnostic services for their newborn hearing screening when we compare it to a typical year of 2019, which means in this year, in 2020, we're going to have approximately 231 babies who are expected to have undiagnosed hearing loss in that year. So we are keenly looking for solutions on how to figure out how to decrease that number because of the importance of identifying babies as soon as possible.
Thanks for sharing that, Dr. Finland. We may have some questions about that in the Q&A.
Sure.
Fantastic. So I think, again, the whole point of this discussion is to reflect on what you had to do, what worked well, what maybe didn't work as well as you had hoped, and really think about what can we use as a framework for future emergencies. Because while we hope that there will never be another pandemic, the reality is that there will be other kinds of emergencies, and how can we as a newborn screening community be better prepared for that? So in this last section, we'll just ask the panelists to share, again, now that you've done this for a year, what would you use as a framework? What would you continue doing for future health emergencies or non-health emergencies? So Dr. Finlan, I'd love to start with you here and just kind of general thoughts on what you think the lasting impacts will be on newborn screening, and particularly in light of the data that you just shared, any specific thoughts on that you can share at this point on how to potentially reduce that number of, potentially missed infants.
Yeah, absolutely. So overall in the US, about 25 to 30% of babies who don't pass their newborn hearing screening never get a timely manner. So we also lots of follow-up issue in our EDI programs. And COVID just kind of was a stress test for that, right? It made it more easy for people not to follow up, only because there was reduced in services, and there were also just this reticence to go in for testing. Because unlike other health issues, we cannot do telehealth for this type of testing. So the one thing that I think could be a really important framework is that education to medical home providers and to families to really stress the importance of follow-up. And I would think that it's an argument for all newborn screenings in general. Newborn hearing screening doesn't have as good numbers when it comes to follow-up because it's not seen as a life and death situation necessarily compared to other metabolic disorders or cardiac disorders that are picked up on labs. But it certainly makes a significant difference on quality of life and eventual academic experience and achievement. So I think the best thing that we can do to quell these lasting effects is education of families and education of providers to really drive home the point that newborn screening exists for a reason. It's really important to follow up on it because we need to identify these disorders early and provide the early intervention that babies and families need.
Yeah. Totally and obviously agree, specifically from the Newborn Screening Family Education Program. I think, these are exactly the things that we want to be able to help support doing. And so, we look to collaborate with others to ensure that that type of education, both for families and providers, is available and that it's uniquely positioned based on what we've learned from this process so that we can emphasize the importance, not just of newborn screening, but of follow-up when follow-up is needed. So Dr. Suhendra, I will ask you a similar question and just ask that you share a little bit with us about the lessons, kind of, again, reflecting back now on a year, what would you continue doing and what lessons can you carry into future care models for families that might be going through emergency situations?
Gosh, telemedicine has really changed everything. And I hope that it's something that really continues for a long, long time. And I hope the insurances continue to compensate providers for their time for providing this service for patients. It's really, like the slide says, it's really a great way to be able to help out a parent who's got a sick child or even a normal child but is asking questions about their kids without having to expose them to a clinic full of sick kids or, most times people have, if they have one kid, they might have two or they might have four, and trying to get that whole crew in the car and someone's got nap time, someone is hungry, and versus if they can just sit in the comfort of their house, you can also see these kids, how they're acting like in an environment that they're comfortable in, so versus when they come to the clinic screaming because they know this is where they get their shots. So telemedicine has really changed a lot of stuff for primary care, and I hope that it is here to stay.
Fantastic. Dr. Gambello, I think you have similar thoughts and even have shared similar perspectives in terms of being able to observe kiddos at home in their natural environment. So yeah, what thoughts from you on that?
Right. So, it's not like telemedicine and telehealth is a new concept, right? This has existed for a long time, and the proponents of telemedicine will tell you that. But you could not bill for a visit in somebody's living room, okay? They had to go to a specific telehealth center. And if one wasn't set up in Macon or Savannah or Valdosta and you didn't have a contractual agreement, you couldn't do it. So, as Dr. Sahendra said, I hope insurance companies continue to reimburse for telehealth visits in people's houses, right? Because I think that there are times when that could be fantastic. And I will tell you, we have a developmental pediatrician in our office, and she says it is very different to observe a child in his or her own play space as opposed to bringing them in and giving them all these new toys to play with and trying to evaluate their developmental trajectory. So there are a lot of advantages of telehealth, and like anything, it has its limitations.
Yeah, absolutely. Any other comments from the panel before I summarize, and then we'll certainly open it up for a Q&A from the audience. And there may have been some great discussion in the chat already. Great. Let me summarize then, and we'll open it up for Q&A. So again, just utilizing the framework of thinking about what did we start, what did we stop, or what do we need to stop, and what do we need to continue? I think you've heard a tremendous amount of just experience and strategy around thinking through that. So in terms of things to think about starting quickly, it's quickly assess what the barriers are and identify reasonable solutions. And so I think in those emergency situations, it's okay to pause and say, what works right now? What doesn't work right now for families? And how can we really think about supporting them given the current situation? And it sounds like from all three of you that was really something that happened quickly and early on. I think one of the things that was really paramount as well were some of those specific tools that helped guide decision making. So from triage or education, or from the perspective of just really helping people understand the importance and necessity of newborn screening, even though COVID was happening, was really, really a key point, and it gave something tangible for families to utilize in that moment. So thinking about similar models in the future. And then I think something that I really heard resonate from all three of you is just the level of communication that was required throughout the process and throughout the system. So communication, obviously directly with families, but also within your individual institutions, and maybe having to step outside of your particular area and work with your hospital administration, or work with your practice partners, or work with your community or state programs, but really kind of thinking about, you communicate often anyway, and normally, but really increasing the level of communication that's needed during these emergency situations. And I think all of those starting are really, all of those things that you start are really meant to minimize and stop the potential interruptions that could happen or occur due to an emergency. And so really thinking about how do we stop or minimize that gap in the process. And then in terms of framework for continuing, clearly, as all of you pointed out as well, telemedicine is not new and it is here to stay, but I think we've learned a lot in this process about how to really improve the telemedicine experience for families, it is more routine now. It is something that is more widely acceptable. And so I think we have to move into a phase of how do we ensure that now that we're using it and it's continuing, that it is an ideal experience for everyone involved, the family, the provider, and others. And then lastly, and I think this is going to be the really interesting part of where we are now in this process, is we're going to have to assess and continue to assess the impacts that COVID-19 specifically have had on long-term follow-up as it relates to all components of newborn screening, and really think about strategies to minimize any potential lost follow-up. So we really appreciate all three of you for your willingness and vulnerability to share what you did in these moments. And clearly, you had to think through a lot of things quickly to support families. And so I think we have a lot to learn from you all. And with that, I will certainly open it up for Q&A and questions from the audience. And I will lean on Natasha, if you are there, to help if there are any specific questions from the chat box that you think we should bring up.
Great. It's probably easier if I just chime in. But one question for everyone on the panel is, from their perspective, from your perspective, we're more than a year out. Everyone feels like there's a light at the end of the COVID tunnel. But from you, and from this perspective of within newborn screening and working with families, have we cleared that COVID storm? Are we, on the other side? And or do we still need to look back to resolve any issues, whether it's following up with families, looking at data, or looking at policies, kind of just from your viewpoint at this point in time?
I can probably start off the conversation for that question. Although I would love to be an optimist and say the light is there and everything's going to be great, I can tell you that we are getting more and more infants who are between 8 and 14 months of age coming in for their first diagnostic test. And so I think this is going to be a long time coming in terms of the resolution of the impact of COVID-19 on newborn hearing screening in particular. Because there's a loss to follow-up rate nationally, and we grapple with that in our state of Ohio, we're somewhat used to kids coming in later and getting what we call late identified with hearing loss. That doesn't make it fun or comfortable. And what I would suspect is that we're going to have more of those kids coming in later and later, and hopefully with some good education and some advocacy on the state level, we can really get parents and families in faster and sooner to decrease any long-lasting effects. So I would love to say the light is there, but I think we're going to be dealing with this for a long time, at least from a hearing standpoint.
Thanks, Dr. Finland. Dr. Gambello or Suhendra, anything to add to that?
Well, I think that there are still families who are reluctant to come to the medical center. So, we still give families the opportunity for telehealth if we think it's appropriate, right? There are certain babies, it just depends on what they screen positive for and whether it's a critical high or not. But so I still think that there are some challenges with follow-up, as I said, getting testing done for children who live far away and laboratory draws are kind of difficult, or the family doesn't really understand the importance of, they receive the requisition and they need to now go out and get the lab drawn. Whereas when they come and visit you, it's sort of part of the visit that you tell them, now you need to go to the lab and then you can go home. So, I think follow-up remains a challenge. And I think follow-up has always been a challenge to some extent, right? Regardless of COVID, right? That's why we have a follow-up program, right? Where people are dedicated to making sure that these children are followed up.
So oh, sorry, Dr. Sundra, did you want to add?
I was just going to add something really quickly. Something also that I think that has come out of this pandemic is a lot of mental health issues. And I've seen a lot of exaggerated postpartum blues, depression. And with regard to newborn screening, when we talk about abnormal results, I have some parents who are hesitant because that possible diagnosis just blew them out of the water. And so I feel like mental health is going to continue to play a big part in not just newborn screening, but just healthcare in general. So I guess we'll just have to wait and see where that goes, though.
Yeah, I think you are dead on. I mean, that is very, very true, especially when you're trying to explain to a new mother who has significant postpartum depression, the importance of follow-up in her right? I mean, they can't assimilate it.
Yep. One last question. We have a couple of minutes left, and I think we've touched on this to some extent, but maybe just in a slightly different way of asking. So one of the questions that has come across is, because of clinical care interruptions and no in-person visits during COVID, do you all think that newborn screening has become a higher priority?
I can start that one off, I guess. I have experienced in the past where we've had some parents reject or decline the newborn screen in the hospital, despite nurses and physicians telling them this is something that needs to be done. I don't come across that so much anymore, but I certainly feel like the first newborn screen to me is very important. And then, like I mentioned earlier, in Texas, we have that second newborn screen. So that has been challenging. It's a little bit easier to tackle when I'm able to provide that service in my clinic. So when they come for their follow-up, I'm like, look, we're doing it today. Here's the heel warmer. So, but it has been high priority for these babies, especially if you have some people who are doing like home births or birthing centers, stuff like that, just to make sure we have that adequate follow-up.
Yeah, definitely hearing follow-up as a key theme from this. So I think that's helpful to hear from you all. And again, lots to take away from that. So I think as we are wrapping up, a few quick things. First and foremost, thank you again to the panel and all three of you for sharing. We are so grateful that you were willing to spend your time with us this morning and to help us learn a little bit more about what we can do and what we can think about. We would love to have one final piece of input from our audience. If you wouldn't mind sharing a bit about your thoughts regarding this overall webinar session. Did you enjoy it? Would you like to attend a webinar like this again? We're certainly always seeking that input and ways that we can think about, just supporting and improving this process for everyone. So we appreciate your input there. And then while you are responding to that, I did want to just quickly highlight that we will be aiming to have our second session in this series in late April. And we are looking to invite a panel of representatives from various different state programs. So we are excited to continue this discussion from a different viewpoint and a different perspective from within the newborn screening community. And so stay tuned, more information will be coming regarding the time and date of that webinar. And lastly, if you have any questions, please don't hesitate to reach out to me directly, either about this webinar or about the Newborn Screening Family Education Program. My contact information is here. And thank you again for joining us today. Before you leave, please share your thoughts with us in the poll, and we look forward to seeing you all return next month. Thank you and have a wonderful day, everyone.